Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
Go above and beyond.
they become very good at what they do, but only
0.1%.
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
With Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Tyler Rouse. He's part of the Legends of Surgery podcast. And I'm going to interview him on my podcast, and it sounds very intriguing. So, Tyler, thanks for coming.
Yeah, thank you for having me.
Tell me about your background. Why would you do a podcast about surgery?
Well, it's a good question. So I am a physician in Canada. I specialize in anatomical pathology, but I've always had an interest in the history of surgery and medicine in general. Actually, I was thinking about this podcast and an interview and looking back as to how I got interested in it. I certainly remember as an undergraduate, there were these big paintings with historical moments in medicine, and I love them. I wanted to read more about them, find out more about them. Got into some podcasts, and there's been a few great ones about the history of medicine, but none that really specialize in the area of surgery, which I sort of have a personal interest in. So I decided to give it a shot.
And how long have you been doing the podcast, and how many podcasts have you done?
I think it's been 3 years, I believe, and I'm in the mid-90s in terms of episodes. So it's been a learning experience. It's sort of evolved as I've gone along.
I don't know. What are some of the memorable podcasts that you've done? What jumps out into your mind?
I think what I found the most interesting, or sort of didn't expect, was the fascinating part of the history isn't necessarily just the operations or the discoveries, but the people behind them and how they got there. And there's been some really even controversial ones that I've been interested in. For example, I don't know if you followed the story last year. In New York City, there's a statue of J. Marion Sims, who is considered the father of modern gynecology. It's in Central Park. And for a long time, he was sort of revered as a hero, et cetera, but people kind of became aware of the fact that he actually did a lot of experiments on slaves, and without any pain control and some kind of very horrible things. And people became aware of this, and actually the statue wound up being taken down. So I think it's interesting to not just turn these these old names into heroes without kind of questioning who they are in their background, and understand that they are regular people with flaws, and sometimes it's circumstances of the time that they lived in too.
Coming from your background, when you approach surgeons to interview them, I mean, I would think they're incredibly busy people. How do you even get them onto the podcast?
I don't do many interviews at all. I've had a couple, but I predominantly it's just my own research that I hoard. Yeah. So yeah, you're right though, that there's been some interest in a few different surgeons that I've spoken to, but most of the material I cover too are people that are no longer around.
It'd be interesting if you could, be allowed to be in a surgery, not as a surgeon, but as an observer, and to kind of make notes on what you see from the observer's point of view, and, with their permission, of course, and maybe do one like that, live commentary on what you see.
Yeah, I actually do assist in the operating room quite a bit here. By doing that, I have the unique advantage of seeing different specialties operate. I think a lot of people don't really see anything outside of, where they work in their specific field, and they kind of get trapped in that silo and don't really see what's going on in other specialties. So that's been quite interesting too.
Well, tell me about that a bit. What do you observe in an operating room that, all I know about surgery is I've gone in there, I'm talking to someone, the next thing I know, I'm like, oh, and I'm waking up. So obviously I'm not cognizant of it, thank God, but what do you observe that's interesting?
Well, you're right. Time doesn't pass for you as the patient, and the way it does, obviously, for the people involved. What I've really been thinking a lot about is just the history that's behind every single part of the operating room, from your washing your hands to putting prep on a patient, like for antisepsis, down to the instruments that we use that are named after different people. It's just the entire operating room is just imbued with this history that not everybody's aware of.
Yeah, why do they call it theater over in Europe? Did you ever look into that?
I have. That's actually Another sort of interesting thing is that if you look at some of the original anatomical dissection rooms from Europe, like Padua in Italy is one of the most famous ones that's still actually standing. It's hundreds of years old, but it looks like an amphitheater because students would watch dissections. That's how you'd learn. You wouldn't necessarily get to do them. The dissector would be standing at the floor and would point out anatomical structures, and all the students would sit around and watch, almost like a performance. And then when surgery became a little bit less terrifying, when we had pain control and things like that, it didn't have to be super quick. People would go in and watch as well. It became, in fact, they used to sell tickets to operations for even the public to watch.
I don't know. I guess an operation is considered a private thing, but would that even be possible today? Or is that even, as a medical student, I'm sure you have cadaver lab, et cetera, but at least for medical students, is there any thought of doing that today, or is that considered absurd or bad?
That is a debatable question because that has actually been happening. Obviously, with the technology that we have, you can virtually be there, right, in terms of filming it. And in some conferences, they'll have a specialist performing a specific type of surgery that they'll do, and it'll be like a live stream that you watch. Obviously, you don't know anything about the patient's details and their name and their et cetera. So it's meant to maintain their confidentiality, but it has almost come around in a way that people watch. This is obviously not for entertainment purposes, but learning, but it's the same idea.
Well, I wonder if there would be a credit offered to someone getting a surgery if they, just say you can donate your organs. What if you elect to have your surgery live streamed? And so you'd get an offset of the cost to do the surgery because you're helping to educate others.
Maybe. You're in the States, right?
Yeah, I'm in Austin, Texas. Yep.
Oh, okay, yeah. So being in Canada, that's not as big of a perk in that we don't pay for our surgeries directly like that. But it's an interesting idea.
So what else do you notice about doing surgeries yourself or assisting at least? Is it on the surgeon and all the other people involved, like what's the atmosphere or the climate in there? Are they extremely serious? Do they have music on? Like what's a typical surgery look like?
I've been in a number of different ones. I find the academic centers that are much larger and where people don't necessarily work with each other every single day and there's lots of people coming and going, they're a bit more serious. But in a community center where I am, and you work with the same people sort of day in and day out and you become friends and you socialize, it's actually positive and fun atmosphere. People do talk about in medicine about this kind of gallows humor or black humor because you're dealing with life and death all the time. And I think it's a way of sort of dealing with the seriousness of what you're doing. But yeah, there's music playing, there's jokes being told, everybody's focused on the patient, of course, and making sure they get the best care possible. But it is a much more pleasant environment to work in when it's like that.
How about the outcomes? Has anyone done a study where you have like the community environment like you're talking about versus a larger academic center and people don't know each other as much? Like, do the outcomes differ?
Well, I think I haven't seen that specifically other than looking at outcomes in terms of volumes of types of surgeries that people do compared to someone who's a more generalist in the community who may not do as many of the specific operation and suggesting that in some cases, those kind of operations are best done in high volume centers. But I think be curious to know if that actually would, for more common surgeries, if that would change the outcome. I think it improves the morale of the people that work there. And I'm sure, a lot of people have heard about burnout and things like that in medicine and how that's becoming a significant problem during a pandemic, particularly. Like you imagine the mental well-being of physicians and nurses and other allied health professionals is a significant topic. And I think part of having those bonds in your workplace really helps.
Yeah, my theory of why I'm asking you is like, I noticed when someone's cooking you food and they're in a bad mood, the food's not very good. It somehow comes into the food. And so I have the feeling that with surgery, if the surgeon is not having a good day or they're tired or they don't like who they're working with, or even the people that assist the surgeon, let's say the surgeon's real mean to all the other staff and the staff hates working with this person, but they do. I have the feeling that your surgery may not go as well as when you have a great environment, people are happy and they're focused and relaxed. And, I just have that feeling that if that study was done, there would be better outcomes.
Yeah, I mean, it's certainly something that anecdotally you hear, at least the nursing staff or circulating, people that are in the room that aren't necessarily scrubbed in. A lot of them will tell me that it depends on who the assistant is, but how well the day goes in terms of, the surgeon being happy or being sort of short with them, et cetera. So you'd hope that it wouldn't have an outcome, but I mean, surgeons are human, and that's certainly one thing I've seen in the podcast as well, right? I mean, there have been lots of famous surgeons who have done some bad things in their personal lives as well. I mean, these are flawed people, but I guess then the question becomes, how do you protect against that kind of thing, and how do you ensure that everybody gets the best outcomes possible? And maybe that is part of it, is focusing a little bit more on those relationships inside the OR and things like that.
What about if the person getting the surgery, the patient meets the surgeon beforehand? Has that been looked at? Is that a common practice, or afterwards that the surgeon themselves will come talk to the person in some cases versus just the other doctors and nurses? Does that make a difference?
Yeah, I'm not sure. I mean, I know that, again, because we're in a community hospital, it's not a very large one compared to academic centers. Most of the surgeons do, I mean, as a routine, they see their patients before time and, ahead of time and afterwards. But sometimes our wait lists are so long that they haven't seen that patient in months or even over a year in some cases. And I wonder how that affects their patient-physician relationship.
Yeah, I mean, I had, a thyroid surgery 3 years ago, and I knew my surgeon, and I talked to her, and she came to see me right before I went under, and then I didn't see her right afterwards, but I saw her shortly afterwards, and it was just a big comfort to do that. I felt like, okay, I know who's working on me, and I felt better. So I just wonder if that's, again, a common practice, but it sounds like it may not be.
Well, it's good to hear your own personal experiences being positive like that. And, you definitely wonder, when people are so busy, that kind of small human gesture that can go so far kind of gets lost, in the busyness of a day and trying to get, do as much as you can in that day. So I'd like to think that part of the podcast too is a way of reflecting on what we do now, even though it's a study of history. And I think it reminds us all the shoulders that we stand on, as they say, to be able to practice the way we do. I mean, and it's only been really 150 years since we've been able to do modern surgery, and it's been incredible how much it's changed. But I think it makes you appreciate it more when you understand where it's come from, what the history of it all is.
So what are some things that happen in the operating room now that didn't happen even 10, 20 years ago, and then maybe 50 years ago?
I mean, one of the big things is laparoscopic surgery. And I did a 3-part episode on that one, or three episode sort of series on that one, on that topic, because that whole concept of the sort of keyhole surgery or Band-Aid surgery or whatever sort of nicknames that they've given it for the public to kind of visualize and understand, the outcomes are incredibly different. I mean, even surgeons that I work with today who are near retirement didn't even have that as an option when they were doing surgeries 30, 40 years ago. I mean, that has been an incredible change. People don't stay in the hospital for a week recovering like they used to. You can have your surgery and be out the next day. The pain control improvements, the scars, the outcomes. It's just, even in that short window of time, it's made a huge improvement.
We also have, I guess, the Da Vinci machine
that
will do surgeries and it's remotely controlled. What are those like?
That's interesting too, because I did in that laparoscopic one get into a little bit into robotics, and there's some fascinating detail in that in terms of even cooperating with NASA, and just because the technology that's required is not something you can just create from nothing. You have to borrow something that's already been out there. So there was actually some very good stuff about that. We don't have any here, and that's usually reserved at sort of larger centers. And there's been some question about whether it truly does improve outcomes, a robot versus a human. But I think it's a tough one because you're at early stages, right? So you think if you continue to develop these robots, will the outcomes actually in the end be better? There's a great article just recently I read called The Future of Surgery, talking about what happens to surgeons when robots are able to have even equal, if not improved, outcomes. And that's something that's quite fascinating too, right?
Well, I've heard that perhaps the best will be a combination of robot and human, because a robot may be able to make a straighter cut, an initial incision, but the gauging the elasticity of the skin and the pressure, the speed and all that is better for a human. So if you have a combination surgery where maybe the robot actually replaces the assistants and holds open, a part of the body, or, clamps something, or, again, assists with tools, but the human does the surgery, or some form of that where it's cooperative surgery may be the best.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
Yeah, and in fact, there was one of the first robots to come out was actually was essentially an assistant that held the camera, and then you could use voice commands to tell the camera where to look. But then, what does the surgeon bring that the robot doesn't have? I guess you'd think about like intuition, experience, those sort of things that are difficult to measure, but you would assume are important in terms of the outcomes. There's a really actually interesting experiment that they did with a robot where they had the surgeon in one location and the patient and the robot all set up in another. And I forget the distance, but it was multiple miles, I guess I should say. And so you can imagine the technology to be able to operate from another location, right? If you don't even need to physically be in the room. It's such a game-changing concept that it's I think it's difficult for people to wrap their heads around.
Well, if it's an internet connection, you hope it doesn't go out or lag or go,
Well, and there's issues with lag time and things like that, because even though it's a history of surgery podcast, I did an episode on surgery in space, which I thought was a really fun one to do, because the question is, what do you do if we do wind up going to, say, Mars, and it's a 9-month round trip and something happens? What do you do? How do you manage a surgical crisis in that stage? And they've actually looked at things like, well, what did they do in these Antarctica missions when people were, they couldn't be brought out for months and months at a time? And that's actually, there's been a couple of events that have happened in the Antarctica where they've had medical or surgical issues that had to be dealt with. There's one was a Russian, he was a surgeon himself, but he was on the team that went to the Antarctica, and he actually wound up removing his own appendix. Yeah, he had to train the crew how to assist him, and he set up mirrors and hold them for him, and he actually removed his own appendix. It's an incredible story.
Yeah, that is amazing. Do you think that there's going to be any surgeries that are amenable to being done in low gravity or zero gravity environments, like on the space station? It'd probably be something pretty crazy to do, but do you think that's possible or would be advantageous?
I mean, I think it will be possible. And I was quite surprised at how far people have thought about this and even done some experiments on the International Space Station, just in terms of how you would use the instruments, like how would gravity affect things like blood flow, anesthesia, all these kind of, there's a lot of, the deeper you dig into it, the more you realize how many issues there are to overcome. But it certainly seems like it would be something that would be possible. One interesting idea too was, if you don't necessarily, as you have probably heard, the cost of sending anything into space based on its weight is huge, right? I almost use the word astronomical, but it's so expensive you wouldn't want to bring up a full set of surgical equipment, for example, right? So they talk about, can you 3D print instruments as needed? And I thought that was sort of a fairly ingenious solution to that problem.
Well, I know there's 3D printing of various items to go into the body, and I'm sure those would be a lot better and a lot more customized. I've spoken to people that are doing better 3D imaging of people's tumors, so the surgeon can see before they go in what's going on and where things are, or 3D printed livers, where it's not the liver itself printed, but again the shape of the liver and the shape of the vessels and the tumor and where they are. So surgeons can look at that and kind of rotate it in their hands, and when they go in, they're not surprised.
Yeah, and then even the idea of 3D printing customized biomaterials that are going to stay in the body, like valves and sections of aorta for people with an aneurysm, or even sections of bone if you're going to cut out a tumor, say, that's involved in bone. And then can you 3D print sort of a matrix that the body would then rebuild into bone? I like that kind of stuff in the future because you can see where it's come from in the past, right? Not necessarily that 3D printing stuff, but just the idea of we're going to insert something into the body. How's that going to work, right? And then how do we even begin to do that? Like DeBakey is a fairly well-known surgeon actually from Texas, and he made the first graft for an aorta out of a material that he bought at a department store called Dacron, and it was essentially sort of a synthetic material used for making clothing. He bought a section of it, took it home, used his wife's sewing machine, made one, and put it in the human body. Now imagine doing that now. Where we've come from, that's where it started. Now we've evolved to the point where we're 3D printing customized, as I said, biomaterials for the human body. It's fascinating.
Well, I spoke to one person that was looking at implants that were removed later on and what the body had done to them, how it covered them, etc. Do you contemplate that any of that in regards to surgery? What's taken out of the body, is that at least put aside for study besides just pathology? Implants, when they're removed, or you talk to anyone that's looking at what are they covered with, what do they look like, how are they worn?
I mean, I know that is a big area of study. Actually, even one of the things, for example, it's a simple idea, but having a catheter in your bladder, some people have to have them in there long term. They actually develop what's called a biofilm, which is a bunch of basically it's a material that bacteria produce, and then it forms a film over the catheter, which is impermeable to antibiotics, right? So basically, if those bacteria cause an infection, you can't get rid of them because of that. So that is definitely one of those things that's come up that was sort of unanticipated, right? But as we have more and more of these things in the human body, we're sort of learning about how they react and how to manage the issues that come about.
What were some of the milestones in history over time that really improved the experience, such as pain meds, when or ether, I guess it started with, but some of the timeline of these things?
Well, I mean, I've gone all the way back. I've looked at some of the stuff from ancient Greece and Rome, and even places in India and China and Japan, and followed them through that. What really stands out to me, and I thought this is particularly interesting, is that there's such a power of dogma in medicine, or there used to be. This idea that you don't question the ancients, these are the rules. You've probably heard of humors. Have you ever heard of that?
Yeah, right.
Yeah,
so balancing your humors here.
Exactly. So that concept goes back to Hippocrates and Galen and those guys in ancient Greece and Rome, and it went unquestioned for 1,500 years because it was not permitted to question it, right? So that concept of knowledge being unassailable held us back for 1.5 millennia. But once the scientific method sort of came back in the time of the Renaissance and the Industrial Revolution, into that period of time, it started to go into medicine as well. And then you've got things like, where people actually are doing experiments and publishing their data and questioning each other, et cetera. So I was just actually doing some research on one was William Harvey, who's an English physician in the mid to late 1600s, realized that our blood circulates in our body. And it's hard to believe that, but before that, nobody knew that. Everybody thought that the blood was generated and consumed in your tissues, and it didn't circulate through the body, which sounds ridiculous to us now. But he did the experiments.
Well, actually, it is generated and consumed partially, but it still circulates the majority of it. So part of the idea was right.
They're working on the information they had available at the time, but they would literally think you would eat food. That food would turn into blood in your liver, which again isn't completely wrong, but then blood would go into your tissues wherever it was needed and become those tissues. They wouldn't come back to your heart. So just the idea of a circuit was something that took a long, long time for us to realize. So that was one major breakthrough. Another was, as you mentioned, ether. That was 1846. So really not that long ago. Hand washing with a guy named Semmelweis. So his thing, he was in Vienna and realized that women were getting these fevers after they would deliver their babies and frequently die. And it happened in the teaching hospital, but not in the community hospital. So he investigated, realized that the medical students would do autopsies in the morning, often on these women who had died of fevers, and then come up and deliver babies without washing their hands. So they were transferring that.
That's horrible.
But this is prior to the concept of germ theory, right? So nobody understood why, but he said, well, let's try washing hands, kept meticulous records, and demonstrated a dramatic reduction in deaths, and was essentially ostracized from medicine for it, because the idea that he would suggest that doctors are dirty somehow or could pass disease to their patients was so verboten that he wound up actually dying in a mental hospital in his 40s.
Yeah, I think they said a gentleman's hands are clean.
Exactly.
That's what they would say about the doctors. They're not clean. Yeah.
Yeah. So those kind of events are interesting to study and sort of see how it's these new concepts are sometimes resisted initially until they're later on proven to be absolutely true.
Well, what's some of the dogma nowadays that you think needs to be at least investigated to see if it's really the best way forward?
Well, that's a good question. Well, there's been a big movement called choosing wisely. And the idea is we should be using the most recent data to stop doing things that are either harmful or have no benefit. It used to be that everybody before surgery, for example, would get an ECG. And it's been shown that that provides nothing. If a person is healthy and has no history of heart disease, that contributes no useful information. But yet people do it, right? Because that's how they were taught, right? Or ordering blood work every single day on a patient. I remember as a medical student, I would have to try to memorize the values because I knew the surgeon would ask me every single day, what's this person's hemoglobin, et cetera. But you don't need to do that because it doesn't provide any new information, but that's just the habit that you're into. And I think unless you ask yourself and so have that self-awareness to say, well, yes, I do this is my routine, but is it purposeful? Is it improving anything or not? So it's still out there. I think there's still a lot of that, well, this is the way I was taught, right? And not questioning it.
Yeah, and there seems to be a big diversity of skill in surgeons, Like, I get a bit personal, but I had a lateral neck dissection, and my endocrinologist is like, wow, the surgeon did a really good job. You get a nice straight line. And I said, what do you mean? She said, oh, some people had a zigzag and like really a big mess. So I was like, well, thank God I got a good one. Do you have any insight for the public when they're going to be choosing a surgeon, if they can choose, at least maybe this only happens in America? What do you look for to know that the person is good, bad, or ugly?
Well, as you were saying that, it made me think, yeah, that is another one of those topics that is a bit uncomfortable for people to discuss because you're right, there is going to be variation in skill level. How do you measure that? How do you inform the public of that? And then how do you improve those that are kind of behind the mean, right? Because I think right now we focus on sort of basic competencies, right? Meaning everybody, when they leave a training program, should be able to do X, Y, Z, right? But not everybody's going to do those as well as, maybe another person. And in medicine, there's been a long history of protecting those that are not maybe as good as they should be. And I think that is a real problem. There are certainly, there's always the extreme stories that you hear about, but everybody kind of in medicine sort of knows who's the best or who's really good and who isn't so great. The way to identify that from a patient standpoint, I think the only real way you could do that now is to talk to other people who have been to that surgeon. Now, the other problem with that is if they have a great bedside manner but aren't the best technically, you're not really going to be able to identify that unless you hear about bad outcomes. So it's a tricky issue, but I think it's an important one.
Yeah, I believe his name is Martin McHarry. He did several books on this, and he said one way is to ask the other people in the hospital, would you let so-and-so do this surgery on you?
Yeah, and we both laugh, but it's true. And I know that if someone asked me, oh, I'm going in to do this, or, I have this, who should I go see? I would probably give them a certain name or maybe not another name, or at least in the bigger centers. I think everybody that I'm lucky that everybody here is fantastic, but you always know about somebody who's not great. And then there's an uncomfortable feeling to that because they're your colleagues, right? You don't want anything negative to happen to them as well. So it's an issue. How do you manage that? How do you deal with there's all sorts of articles about dealing with the difficult physician as well too, right?
I guess one proxy could be, if you're going to have your appendix taken out, you want to make sure the surgeon that works on you has done this surgery at least probably 100 times. And at least some of the 100 have been in the past 6 months or year, ideally. And then at least you get someone that does it a lot.
Yeah, I think that's a little bit further ahead in the US than it is in Canada, just because you can sort of more shop around. Whereas here, you just go to your family doctor and then they refer you to whoever they refer you to, and that's who you go see, right? But it's an idea, the idea of almost a scorecard or stats about your surgeon. It's I wonder how much resistance that would receive if they tried to implement that here.
Oh, you talked about dogma. It might be.
And I think that's one of the things that one of the benefits of studying history, of course, is also to see old problems and see if they're, still applicable today. Like, I was thinking about that problem of dogma and how much it's improved, but you need some great points in that. Yeah, there certainly is still some of those ideas today. And how do you continue to improve?
Well, what do you see on the horizon in surgery that's coming in the next few years that you think is going to make improvements?
I mean, the technology sort of always moves along. There isn't any specific new technology I'm thinking of. I think the training is, and how we train and evaluate physicians and surgeons is evolving. And I think that's going to make a larger difference. They are now, as you said, sort of that scorekeeping that you're talking about, or numbers, that has become a bigger focus in medical education, this idea of competency. So you don't just, do your 4 years of med school and your 5 years of specialty training and then get spat out, regardless of whether you're capable or not. This is more of, well, you need to do this many procedures, see this many cases of, whatever, until you've accomplished that and you've been evaluated and said, yes, you are capable of that now. And once you've checked off all those boxes, then you're ready to be sort of put out there and operate. Because once you're in practice, really, there isn't a whole lot of scrutiny the way there is in training. So I think if you improve that concept before people are out there, then you're going to see an improvement in outcomes.
Yeah, for liability purposes, do you think there'll be, I don't know if this happens, but do you think there'll be a time where all surgeries are kept on video and encrypted in case there's a problem, later on they could be viewed?
Well, you come across another thing that's actually already out there, or just starting to be. St. Michael's Hospital, I know in Toronto, they have what's called a black box, similar to an airline, right? Where it records everything that happens during the surgery. And if there's an issue, then you can go back and look at that recording. And it's going to record everything, like all of the vital stats, et cetera. So if there's an event that occurs, it can go back and look at, because you're monitoring all of the vital signs, et cetera. You can go back and look at that, look at medications, what was happening in the surgery at that moment. So that might actually become a much bigger way of improving surgery too, in terms of feedback, right? Because if you write down to that kind of granular layer where you can look at the data and say, okay, this is the exact moment when something went wrong, and here's what we've witnessed on this black box, and we can maybe make improvements. Again, going back to dogma, some physicians or surgeons aren't going to want to be recorded, right? How does that affect, circling back to talking about what it's like to be in the room? Do people feel comfortable joking and talking and being, having that camaraderie if you're being recorded?
Right, that's true. Yeah.
Do you think it might be something that takes off?
Well, there could be layers of it. For training purposes, you could have the video with no audio. For legal purposes, you might have to have everything, or certain things would be kept hidden. You could put a blue dot over people's faces. Certain voices, again, could be, taken out, or certain parts redacted. And the video could be used for many, many different purposes.
Yes. Yeah. I remember interviewing a potential medical student who was working on this exact project, actually. And the possibilities are pretty exciting. So it's just, again, medicine is a little bit slow to adapt or to take up new changes. So even talking about robots, et cetera, how many places actually have one? This black box concept, you wonder how many places will be willing to take that up, how much resistance you might see to that. That could be very interesting.
Well, if they offer discounts on malpractice insurance and other types of things, that would probably be a big incentive and pressure for hospitals to use it. But again, it could be used for bad things. You'd have to watch out, and there'd have to be a lot of debate around it to make sure it's used in an ethical way and not to, to hurt people.
Yeah. Absolutely.
Is there a surgical place that you look at as, like, I hate to call it the gold standard, but I don't know, like, what's the most innovative, amazing hospital or clinic or place that does surgery that you've observed, and what's different about them, if so?
Well, yeah. So to me, what I have heard about, which I think is quite interesting or quite innovative too, is I believe it's in the Cleveland Clinic where they do this. The routine is usually, you have a problem, you make an appointment, you get a biopsy, That biopsy then gets read by a pathologist, and then you come back a week or two later to discuss the results and book a surgery, etc. Some places, as I said, I think it's the Cleveland Clinic, where they will take a biopsy. You go that day, you take a biopsy that day, they do a quick, what's called a frozen section, so they can make a diagnosis immediately. And you can even be booked for all your pre-testing, etc., all in one day. So rather than having people wait around and having that delay of weeks at a time between diagnosis and surgery, you could cut that down to days. And there's only a few places that I've heard about that are doing that, but I think that, imagine the reduction in wait times, in anxiety that patients feel while waiting for those results, etc. It's quite a fascinating concept where you can streamline all that care sort of in one visit, potentially.
What makes surgery incredibly difficult? What are some of the factors that make it hard? Is it, an 8-hour surgery makes total sense, much harder than a 1-hour surgery? Are children harder to operate on? Like, what makes a surgery more difficult?
From the technical standpoint, yeah, as you said, obviously there are some that are more physically demanding than others based on sort of the length of time, or if you compare something like, an orthopedic surgery that involves a lot of, physical work versus something that's a bit more finicky. People use microscopes in surgery. I think that's one of the more technically challenging things to do, where you're using sutures that are so fine you can barely see them with the naked eyes, and to make, to be able to use that to suture something together is incredible. I think that's sort of near the pinnacle of technical difficulty. But if you ask most surgeons what's the hardest part of their job, it's not the technical aspect. In fact, most of them, not surprisingly, love being in the operating room, and that's the day they look forward to. It's deciding when to operate, because that's what takes the longest time to learn and to really get a feel about that, right? Because it's easy to say yes to everybody that wants a surgery. It's much more difficult to know who you should say no to.
Any other factors that you're aware of that really would impact, the success of a surgery? Are there certain kinds of surgery just are notoriously difficult for some reason that, I wouldn't know about?
Brain surgery is a very challenging one in that you're off by a few millimeters and you can do some fairly significant damage. It doesn't have the room for wiggle room in terms of making sure that you make the exact right cut. I think that would be certainly one people would think about. I would say this, if you don't mind. In the history, too, of surgery, a lot of famous surgeons have been quoted as saying things like, we'll never be able to operate on the heart, right? Because nobody could think of a way to operate on a beating heart until somebody came up with the idea of bypass surgery, right? Of being able to bypass the heart in terms of the blood flow. But when you read stories about those guys in the 50s and 60s, the real pioneers of cardiac surgery, it's incredible. I think that's probably, in terms of historical time as well, what has been some of the most technically challenging things to do. I would have to put it in that category.
Yeah, I guess like nowadays, if you would try to operate on a single nephron of a kidney, that probably would be like incredibly difficult. Really, really tiny stuff would be hard.
And I think that's what we're getting down to. as we improve our ability to identify things earlier and smaller, is to be able to minimum damage as well, right? In terms of, and that's the laparoscopic concept, right? Is that you're making less of an incision, you're doing, you're less modification of the human body, less healing required. But yeah, I think you're right. I think that's, as we get smaller and smaller, it becomes more technically difficult, that's for sure.
You talked earlier, you said people used to have an ECG before surgery, and that was useless, and blood work was taken every day, which was kind of useless. What about antibiotics before surgery? Is that just universal now that people are given that? And is there anything that could be altered in that particular protocol you think that would work better?
That would be a big research question, but the number of people that get preoperative antibiotics has been reduced, but there are definitely some that are still, it's routine. Things like if you're operating inside the joints, for example. I do wonder, I don't have the data, but you think, is that effective for everybody? Is that, what happens if we didn't do that? That's one of those problems where you go back to dogma. You say, well, everybody gets those antibiotics. Is it ethical then to do a study where you randomize that and some people don't? And what if they have a negative outcome, right? So some of that dogma, it's challenging to overcome. I think you're making the general point that antibiotic overuse is a huge issue in medicine, and surgery is not exempt from that. But it has been reduced, I think, but probably there's still some areas that could be investigated.
Okay. Well, very good, Tyler. So how do we get people over to your podcast? Where can they go? Where is it listed and posted?
It's on many of the podcast streaming sites. So it's Legends of Surgery. I have a Twitter account and Facebook, so people can contact me. It's at Surgery Legends. Unfortunately, Legends of Surgery was one character too long. And Facebook is Legends of Surgery. And hopefully people can get there and then download and enjoy some shows. There's all sorts of different topics there. So lots to peruse. Fairly good catalog developed now, which is kind of nice.
Excellent. Yeah, and the sophistication level of the listener, they can be a layperson and still get a lot out of it, or do they need to be scientifically knowledgeable?
I think I try to create them so that there's a bit of both. I think sometimes I do try, it's hard to avoid some of the technical stuff, but I try to explain it in a way that someone who, with a bit of a science background can understand, not necessarily medical. And because there's so much overlap between, the world of medicine and the world in general, I try to include a lot of sort of interesting historical tidbits and information too that isn't necessarily surgical, that I think people might find interesting too. Yeah,
excellent. Well, Tyler, thanks for coming on, and I encourage listeners that are interested in surgery, definitely to check out your podcast, Legends of Surgery. So thanks for being here.
Well, thank you for having me.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.